Looking forward. All right, welcome everyone. Good afternoon. We're going to give it just a minute before we get started. Thanks so much for joining us again. I know we're starting to get into the summer season in our northern Midwestern state, and I know folks like to be outside. It's rainy here in Lansing today, so not much sunshine, but yeah. All right. Do we want to shift? Okay, great. All right, we have a very short amount of time today. We're together just an hour, but we are really looking forward to today's discussion. We're going to hear from two of our healthcare providers in the group and two of our parents about their experiences. But before we get to that, if you all could drop in the chat your name, your role, and one thing that stood out to you from our last session, if you were here during our last session. And I can go first. Jessica Hamill, my pronouns are she, her. I work at the department on local maternal child health issues. And then one thing that stood out to me from our last session was like the quality of care that folks receive when they are within a PCMH setting. That got uplifted a number of times. And then we also, so that really stuck with me. And then like the role of care coordination and how important that is. And one thing I didn't realize is that practices, at least if they have a Medicaid population, can bill for care coordination without having PCMH designation. So that was something I learned last time. Yep, care. Yep, and several people uplifted importance of care coordination as well as like the challenges. Coordination is so important for parents and caregivers. Oh, workforce stood out as well. Care coordination and billing, education for parents. Yes, that was, nobody knows what medical home means. We need to work on that. Certification varies by ParaSource. No, that's okay, Laura. We're glad you're here this time. That's okay, Krusty. All right, Sarah, that's okay, Heidi. I know you had Paige here last time, so we're excited that you're able to be here this time. Okay, and Lonnie said what stood out to him last time is that a lot of practices are already doing PCMH but don't have the resources to document this work, which is needed for billing. And Sarah mentioned regarding opportunities and challenges to getting and maintaining designation. And Dr. Gilmer, PCMH accreditation sounds complicated. It sure does. All right, looks like we have slowed down. Well, we are super excited. Oh, Kristen, thing that stood out to me, medical home movement seems very easy top down, but the need for patient parent education for sure. And welcome to so many of you who were not able to make it this time. Thank you for making space and time on your schedule for today's meeting. We're happy to have you. And yeah, all right. Lindsay, am I good to, or no, maybe it's Gloria this time?
Gloria today. Yep. Thank you,
sorry,
Jessica.
sorry.
It's okay.
I'll get there.
No worries. Hello, everyone. I'm just going to go through a little bit and share a very high level of some of the discussion from last time. And since we're short on time today, we want to get to our panel discussion. Just going to highlight a few things. But a number of supportive resources or strategies were mentioned in terms of pursuing medical home designation, such as increased staff. That was one thing that we talked about, kind of that challenge, and also practices sharing staff in some way, coming up with creative solutions for the limitations that were brought up. Identify champions as a way to model change was brought up as a successful strategy, as well as having an experienced biller in practice who is familiar with all of the reimbursement codes. And just to highlight a few, please do dig into the slides and review the rest. Next slide, please. And then we also heard about a number of policies and practices that are either supportive or kind of function as barriers to implementing a medical home for children. Some of the more supportive policies and practices that were mentioned were some flexibility in accreditation standards, having some financial incentives such as increased reimbursement, and there being ways to kind of let practices share with one another, and some flexibility to cover telehealth. Policies and practices that were more of barriers. So even though there are some financial incentives that came up again as a barrier, as this still is somewhat limited, and particularly for clinics that have a high population of Medicaid enrollees. And again, with Medicaid, there being potential cuts to Medicaid programs at the federal level, and those eligibility determinations negatively impacting coverage rates. We also had a lot of discussion around how it's kind of can be seen as burdensome to go through the accreditation process, how it's really hard for smaller practices to have 24/7 call service and have a full staff on board. And we also talked a lot about care coordination and how difficult that is to maintain care coordination staff with burnout and lengthy onboarding processes. So that's just to give you a little bit of an idea of what we talked about last time if you missed, but please do check out the recording and read this more in depth if you want to figure out more. All right, and so for the rest of our time together, we're going to hear, as Jessica mentioned, from two parents and two healthcare providers about how they perceive the effects the policies and practices have on the medical home for children system. And after the panel, we're also going to do a little bit of group brainstorming together. And today we're going to have this panel focusing on parents and healthcare providers as part of the medical home ecosystem, focusing on those groups. And we'll be particularly focusing on how healthcare policies and practices impact how families receive medical care for their children. So we have 4 awesome panelists today. First, we have Tia Barnett, who is one of our parent representatives. Tia lives in Flint, Michigan, has a toddler and a newborn, and also has professional experience within the healthcare system. And next we have Dr. Robert Van Houw, who is one of our provider representatives. Dr. Van Houw is board certified pediatrician, who's the current medical director for 4 local health departments in the UP of Michigan. Next, we have Vanessa Ferguson, who is our next parent rep. Vanessa lives in the Flint area as well with their husband and 8-year-old daughter. Karis is adopted, and since her coming home at 2.5 years old, Vanessa and her family have navigated several diagnoses for Karis. And finally, we have Dr. Christopher Youngman, who is our next provider rep. Dr. Youngman is a board certified pediatrician who provides healthcare to infants, children, and adolescents. And in addition to this role as a pediatrician, Dr. Youngman also serves as the practice's chief medical officer. So with that, I am going to pass it on to Sarah, who's going to be the MC for our discussion.
Thanks, Gloria. Just a couple of reminders for everyone in the audience as we get started. Much as we did last time, this conversation is essentially acting as data for this assessment processes, so we can all better understand some of those policies and resources that impact healthcare received by children. So there'll be time at the end for questions. So you can pop them in the chat and we'll do our best to address them so we can all learn as much as possible. I also wanted to give you a heads up. On the screen is a slide that we're going to be posing to everybody in the audience to answer at the end of our time together. So please keep this question in mind as we go along. What changes do you think are needed to make the medical home approach the standard of care for providers and families in Michigan? And as we mentioned last time, these ideas that are generated will be kind of the foundation of our brainstorming about how this group can potentially make a difference in our kind of action taken together. So feel free to pop your ideas in the chat as we go along as well. So we're going to stop sharing the PowerPoint and transition into our panel. So we're going to spotlight all of our panelists here. And thank you so much for taking time out of your busy schedules to join us today. I'm going to start our first question with one of our providers, Dr. Youngman. So last time we met, our system partners shared their thoughts about resources that they see as supportive for clinics to be able to successfully adopt and implement that medical home standard of care. Gloria touched on some of those they mentioned in her intro, included things like support for practices as they go for accreditation, staffing and workforce development, having champions and committed staff, as well as, training and experience for billers and care coordinators. So starting with Dr. Youngman, what more would you add about resources that are needed for clinics to successfully implement the medical home standard of care?
Right. So yeah, there's a lot of advantages to medical home for both the providers and patients. There is quite a bit of infrastructure that's required. And depending on what type of certification, I've actually, when I was working in Omaha, accredited 15 of our offices with the NCQA's medical home certification. And that is a pretty big lift to do. Our system, we were fortunate enough to be associated with the Children's Hospital there, and the hospital itself owned the incidence of Epic and worked directly with Epic. So we had to utilize the IT support pretty heavily to develop the reports necessary to really dig down into our population and find ways for meeting a lot of the requirements that were required. Fortunately, this time around, being in Michigan, we partnered, our clinic partnered with the Oakland Southfield Physicians Network that had already worked to establish a lot of those reports from the payers themselves. And so we were actually able to get accredited and recognized much quicker than it took with Omaha. Omaha felt like we were building the wheel from scratch, and which surprised me because a lot of these things are national metrics in terms of HEDIS, which even though that's typically applied to the third-party payers to measure their performance, they've kind of flipped it and pushed it onto the providers. But I was really surprised at how little the electronic medical record systems, even one as sophisticated as Epic, really had not built much internally to really look at these things and help support the providers as they move forward. So one of the things that's really necessary is accurate reports on your population, and ways to measure and implement changes, process improvement is extremely important, and that's a big part of patient-centered medical home.
Thank you. So, yeah, I hear you talking about kind of having a good medical record system and maybe having supports from other clinics to maybe help figure out how to use your system to pull the reports you need for quality improvement and accreditation purposes. Is that fair to say?
That's definitely, yeah. And then you need your care coordinators, as well as your clinical staff to be able to work reports and get families to come in, do outreach to families, and with the way the attribution system works for assigning of patients, it's very um, uh, can feel arbitrary to the provider. You can get assigned patients that you've never seen before. They may be outside the age range that you typically see. I always find it funny as a pediatric practice, we have, some of the metrics for people age 65 and older, and you're like, oh, that's clearly an interesting way so that you have to be able to find out who your population is so that you can work to spend time to clean that up, as well as actually implement changes to improve care to those families that you have been attributed to.
Thank you. Okay. And this question is for Dr. Youngerman or Dr. Van Hou. We talked about last time the care coordinators and billers, there being a bit of a learning curve when it comes to providing the services, generating the reports, those kind of pieces, and there being a high possibility of turnover due to burnout in those situations. Do you know of any training or other supports available for those professionals currently to learn what they need to do that job?
Well, again, we partnered this time around with the Oakland Southfield Physicians Network, and they actually have developed some trainings for our staff to be able to learn how to do the billing component. I'm not saying that's easy, because often as not, any of our trainings, including the physicians, we're not trained how to bill appropriately, or as much of the focus of our education is on that. So it's a very difficult process. Some of the outreach that they do, they don't realize it is billable. But then also, how do you track some of it? Because some of it you're allowed to bill X number of minutes per month. And that can become a challenge. And again, the electronic medical records could be more supportive in that regard as well. So to allow those minutes to be added up and registered in reports by the end of the month.
Okay. So in addition to the kind of technical aspects, it sounds like that peer training relationship that you had was really critical with that other physician group. That's really interesting. Dr. Van Hou, is there any other resources that you would add that seem critical for helping clinics successfully implement medical home?
Well, more and more practice, especially in the more rural areas, they're owned by hospital groups or health systems. And I think getting the health system on board for what you're doing and understanding what you're doing is essential. Oftentimes, you'll have a 2 or 3 pediatrician practice as part of the hospital's group, and the administration usually doesn't understand what pediatrics does. I remember one time I was in a 2-person group, and we had 3 nurses, and they couldn't understand why we just didn't have one nurse for each doctor. And he says, well, we have one who just answers the phone calls. And so we had the administration person sit next to that person for one morning and said, yep, we definitely need that person. And I think this understanding what we're expecting those people to do, hopefully that'll alleviate some of the burnout. The other thing is that I was thinking about ahead of time was I was in a practice where we were the only group in in the system that had someone answering the phone. Getting a human being to answer the phone really makes you feel at home. And I couldn't believe how many comments I got from patients about the fact that we were more accessible in that way. I think sometimes the administrations see this as a source of income, but they don't understand what resources need to be allocated to do it properly. So I think some of it's a matter of education for the health systems, why this is important, because it's one of those soft things that is hard to measure how much money it's saving or how much health it's preserving. And you know, the billing part of it is its own little rabbit hole. So yeah, and don't expect the physicians to understand it.
Mhm.
One of the roles of the electronic medical record that should be emphasized, but as Dr. Youngman pointed out, is lost, is that it should be there for us to capture the information on what efforts we're doing. And it doesn't do that very well. You know, whether it's screening for this or that or the other thing, clicking the right box in the right place so that you can bill appropriately. I didn't learn that in medical school.
Yeah, that's not a critical. Yeah,
Right.
absolutely. Okay. So, just quickly for either of you, what motivated your practices to become designated, in whatever accreditation model? And if was it financial incentives or something additional?
Well, back when I did it originally, I think Blue Cross Blue Shield was offering a unbelievable uplift in what you could collect. And what happened is that there were so many, they didn't expect many takers on it, but basically they had so many people, hospitals that were interested in it, they reduced the uplift by a lot less because they couldn't afford it. But there was certainly a financial incentive was there.
Yeah, and I think that's one is the financial, but also just the dedicate, the ability to express the families the dedication to whole person care. And that is of a value within our organization. And that was the reason why we sought to do it.
Absolutely. Great. Thank you. Okay. Speaking of families, let's go to a parent rep next. I'd love to hear, Tia, your take. What resources do you think, based on your experience, children and their families need to access and fully benefit from care provided in a medical home?
I think based off experience, so my background, I've worked for a federally qualified health center for the past 5 years as a community health worker. So I am basically the liaison between the parents, the patients, and the providers. And I actually connect people to resources that they need. So if a patient comes in and they say they don't have transportation, they need help getting food, any type of social determinants of health, they get referred to a community health worker at our center. And then we help navigate those different items, which I think community health workers are someone who can be that in between is needed, because the provider doesn't, they don't have time to do that. And if someone does need transportation or they need help with housing or they need food, that directly affects their health. So that is one resource I think needs to be implemented in different facilities. Something that has not been talked about is education. So as a community health worker, we also help educate the parents. So as Dr. Youngman has said, they get attributed patients that they are automatically assigned. So say someone's insurance gets assigned through Medicaid and they get United Healthcare as an example. if you don't choose a provider, you're automatically assigned a provider. So some people, even though you're supposed to get letters in the mail, you're supposed to get something online, they don't even know who they're assigned to. And so that patient being assigned underneath Dr. Youngman is a part of his patient, even though he's never seen them, which affects that quality score that they're getting because it's showing that they haven't come in for a well visit. Another thing is basically, like they said, champions in the workforce. So say something as simple as getting the correct phone number, having just a basic practice of care, getting correct phone numbers and address so you can contact that patient, so you can call, if you have the staff to call them, you're due for this annual, you're due for this checkup, you're due for a blood pressure screening. So that could help get those measures correct and down. Helping them navigate on how to find resources as far as transportation, how to navigate using a care or their insurance's care management program that typically most of people have through their insurance as well. Another resource that I think is needed is some way to train the people of the medical facility. So it's basically, I feel it's not enough time in a day for sure. So you have a provider start and it's a new, EMR that they're using. Is it on the provider to try to build the correct care plan in the system so the codes can be documented correctly or the notes can be documented correctly? Or is that on the biller to try to catch that on the back end? And I feel it's just not enough education on both ends that is not being caught. And then it's also showing basically that the patient didn't get what they really did get when they came into the office because it's not being documented or caught. I personally have worked with trying to clear, HEDIS measures. So we're calling people who are due for a cervical cancer screen or a breast cancer screening. But if I just see it based off of the population health breakdown or the chart that says that they're missing it, but I have to spend 15 minutes in the chart looking to see if they actually got it done. And I do see that they actually have a scan document from the imaging place, which is how come I found out that they actually got the procedure done versus me seeing it documented in the chart that they actually got it done, which is why it's not showing on the back end of on the larger population health system that we use. We use Athena, and then we also use Azara, and it's a care coordination part of that and a care management part of that. But yeah, it's a lot. Another thing I think would be nice is when patients go to the hospital, typically if they have an assigned provider, that hospital record is sent to the provider. But the hospital staff isn't necessarily telling them, okay, this is who you need to go see. They're also typically not helping them with resources. I think they need more help on that end as well. We've tried to, get in touch with somebody who's going constantly to the emergency room, but we can't get a hold of them because there's no correct phone number or a correct address, something that's so basic. And some people are homeless, we do have a homeless population, but someone who could take the time at the hospital as well to work with these patients. Sometimes they do have someone who's supposed to do that, but with my experience, it's not really happening for them to get connected to the resources. Like they could get connected to someone like me. They're assigned to my health center. I could try to get them resources or try to get them to the clinic so they're not going to the hospital for something that's basic.
So many great ideas. Thanks, Tia.
You're welcome.
I hope y'all are keeping track of these for your brainstorms about potential strategies. We might think about implementing this fall. Just quickly, Vanessa, did you have any resources you are burning to add?
I would just kind of build off on what Tia said real quickly about care coordination. Because to be honest, until I was on this committee, I didn't even realize that my daughter's pediatrician was a medical home until I was calling for an appointment after I had been on here. And part of their message before you go to a person says that they were. So just sharing with families the resources that are available and really helping with care coordination, because I think there's a big gap for family. If you're lower income, you can get resources like some of the things Tia was mentioning, but people who have, like I teach at a college, I don't have access to those resources, and I become my daughter's care coordinator. So looking at additional care coordination options for families, especially once you get to more complex medical needs, that's where I've seen a lot of families, those things fall through the cracks because we focus so much on immunizations and wellness checks, and that once you get a diagnosis for something and you have to go to that next level of care, I think that's where there's a big drop off in resources for families.
Thank you. I hate to move on just for time, though. I think we have to move to talking kind of more in the policies and processes realm. I'm going to start with Dr. Van Houw this time. We mentioned in our last session a few policies or practices that can support or get in the way of a clinic's ability to implement this model. So, you know, people talked about financial incentives being certainly a support, but also sometimes the level of financial incentive being a barrier. You know, there was discussion about sharing of lessons learned, like Dr. Youngman's practice did, being a practice within the system that can be supportive. There was also barriers around, you know, Medicaid potentially having some unfortunate changes coming up, the requirement of 24/7 access to, you know, care. So all of that being said, there was a lot of discussion last time. What would you add, Dr. Houw, around federal or state healthcare policies or processes that get in the way of a clinic being able to provide families with that medical home level of care?
Well, the financial thing is a big part of it. I think if you have a smaller practice, you're not going to have a full-time person who's doing this, and you're going to put those responsibilities onto staff that's already overworked. So there's that element of it. I think that the other thing that we run into pediatrics that may be different is we have a lot of well patients. Okay, unfortunately, our patients are pretty healthy. The ones that need coordination of care, usually, at least in my setting, you have to go well outside the area to get specialty care. So you know, if it's you know, 200 or 300 miles away to see a certain pediatric specialist. I mean, there is outreach that is done by different networks. But you know, coordinating that is it's a lot of effort made just in a small portion of your patient population that needs a lot of that. So I think the policies on that is pediatrics is different than adult medicine. Okay, and so you know, the specialty care typically is in children's hospitals or large medical centers. And you have to realize that there's the transportation and the coordination that goes into that.
Okay, excellent. Thank you. Dr. Youngman, would you add anything about policies that come to mind for you?
You know, I'd just like to reiterate the financial lift. We looked at taking our entire financial lift from patient-centered medical home and applying it to a full-time medical secretary, and it wouldn't cover the cost of a full-time medical secretary. So yeah, it's not a huge financial reward. So that's definitely a significant issue. And then yeah, the complex patients are definitely the ones that benefit from care coordination and everything else. So it's great when you have the resources to be able to help those that really need it and take advantage of it. It's nice to see that. Um, I think we are held to, because pediatrics is such a predominantly healthier population, most of our quality metrics are based upon healthy kids, and that's not necessarily a true measure of quality. So I think that ways to measure quality and ways to measure effort on these complex kids and care coordination needs to be improved, so that way we can take care of them better.
Okay, yeah. So it's kind of thinking about how to incorporate children with special healthcare needs into the quality metrics. Yeah, you both spoke about kind of the financial limitations piece. Are there other incentives that could be offered given these limited financial resources that could help offset some of those challenges? Like, what other incentives might exist beyond financial incentives?
Well, I would just like to be able to support our community health workers. I mean, from the public health standpoint, you know, they do a big role, and I would see that if you had a clinic that they do a lot of that coordination work, more than just like I said, the person that goes and picks someone else up and takes them to their appointment. And it's a model that is starting to be tested more than it was before, but no one knows how to pay for it yet.
Yeah, can community health workers bill for care coordination, or does it depend on the payer?
I don't know the answer to that. So
I think there's always a way to bill for something. Whether or not you get reimbursed is another story. And what you get reimbursed may also, like some of the telephone calls, you might get reimbursed pennies, and it's the amount of effort that's required to do it is not necessarily worth the return on the investment.
Yeah, some of our pilot projects with community health workers are, based on grant funding. And then when the grant funding runs out, who knows what happens then? Because there's certainly, it's difficult to bill for their time and sustain the services.
I could answer. Technically, care coordination is a part of something that we could bill for. It does have to be a video and audio call or in person in order to bill anything that a community health worker does. And so it's different codes that you can input for that. And I think that you have to spend at least 15 minutes in order to bill.
And do you have to have like a nursing or a social work degree or
No,
something like
you
that?
just have to actually be it's a certification. So community health worker certification through I can't remember the name of the company, but whatever it is, it has to be someone that's certified to train community health workers in Michigan. Where you have to get your certification from. It's only a 8-week training that you complete. And then you have to do continuing education credits to keep that certification.
Okay. Thanks, yeah. And this is for either Dr. Youngman or Dr. Van Ho quickly. Does the health system's overall rating see an impact when they have more PCMH practices or not? This is a question from the chat.
Yeah, I honestly I don't believe so. I think their overall rating is based upon their HEDIS quality metrics. And so patient-centered medical homes are typically more apt to focus in on improving those. So, indirectly, it probably does have a significant impact, but not just knowing that you have patient-centered medical homes as part of your network.
Okay. Okay. So maybe indirectly, but certainly not directly. Okay. So let's, gosh, why is our time always so short? But I want to pose one more question, kind of bringing it back to why we're all here. I'd like to start with Vanessa, if that's okay. I'm wondering if you have a story about a time when your child's medical care was significantly impacted by a healthcare policy or practice.
Sure, I have several, but I think I'll focus on one that probably most people could at least know someone that might have a similar experience. So our daughter received an autism diagnosis last fall, but it took us almost a year to get to that because of the policies that were in place we have Blue Cross, we do have like a PPO plan because, as I mentioned, I do teach. So we have a fairly good plan, but even with the plan, there's policies in place where there's only so many facilities in the state that are recognized by Blue Cross for you to go to get an evaluation, to get a diagnosis. Out of that, there was only one in our area that took our particular insurance, and there was a 7-month wait list for it. Even though we had everything lined up from all of her other therapists and providers, we had to wait 7 months for her to be able to get in for her evaluation, to get her diagnosis. Once we had that, it was later in the year, and we had already ran out of visits once you have an autism diagnosis, the caps are typically lifted for speech and physical therapy and OT and all of that. Prior to the diagnosis, we had a cap of 40 visits a year. So my husband and I always knew we would put enough in our HSA to pay out through the end of the year of our extra speech, extra PT. We went for our eval in October. We didn't actually get the diagnosis in our hands until the week of Christmas. So even though we had went for the appointment, the process that they're required to follow for the insurance to do the formal diagnosis took almost 8 weeks to come in place. So by the end of December, we had been paying for out-of-pocket visits for approximately, I think, 7 weeks. I'm still fighting to get reimbursed because of how long it took with those policies or to get the diagnosis. And now I'm trying to get the medical sites to rebill Blue Cross because they will get reimbursed at the insurance rate versus the cash rate that I paid. So not only did the process to get in somewhere, there was limited availability of places to get in. Then we had the challenge of waiting for it once we were already in. And then, of course, now I'm going back and trying to get reimbursed for a couple $1,000s worth of things that we had paid out of pocket. And all of these are all insurance related policies and things related to how that process has to work.
Yeah, the complexity is certainly there.
For sure.
Thanks for sharing that story. We need to move to question and answer now, but any of our panelists, is there one thing you'd like to add about an opportunity you see existing for providers or parents to be part of moving the medical home standard of care forward in Michigan?
I think just overall education, like we mentioned, not just for the staff at the medical office, but also for families of what this means, because most people aren't going to know. I didn't know exactly what that meant until I've been able to sit in on these meetings. So letting them know the resources that might be there and how that makes a difference being at a medical home versus just at a clinic office, or if you go into the ER or something like Tia had mentioned. So I think education across the board would be really helpful to push things forward.
Great.
Yeah, I think beyond just education would be good to have policy support for pushing the payers to to provide that financial support because of the amount of time and effort it takes to do those things and how it does impact care down the road.
Absolutely.
I
All
think
right.
one way to get the message across is through narratives of, you know, the differences that people or that the coordinators and the community health workers have made in the care of specific kids. Because if you don't have that coordination, things can fall apart pretty easily. And I think parents are off who have a child who has complex needs complex care. They're a little overwhelmed, and you can't expect them to do it all by themselves.
So being able to push those kind of mental models. All right. I see Lindsay, you have some questions for me?
Yes, I sure do. There was one in the chat that I thought was really good and relevant to some of this talk about, you know, really the challenge of, and sometimes the burden on staff. And so Dr. Gilmer asked, how much time and staffing do you feel is needed to generate reports to become and stay accredited? So you had mentioned that earlier about how long it took to sort of really do those reports. It's like once accreditation is established, can it be accomplished within normal workflow? Are you finding that is or is not the case?
I think you know, particularly NCQA accreditation is extremely complex and it has to be done annually. So there's quite a bit of time that needs to be dedicated to it. I was the medical director, and I had a nurse and a secretary under me, and at least 25% of our time was dedicated to patient-centered medical home as an ongoing basis to continue accreditation and make sure that so it's pretty significant.
So there's one additional question, if that's okay, Sarah, that I wanted to bring up. Lonnie asked, regarding care coordination for complex kids, is there much intersection between practice level care coordination and care coordinators through health plans and local health departments? Put that in the chat again. Oh, that's not right. I apologize. Let me try. Okay. And I don't know, Lonnie, if you want to come off and ask your question, if you feel like you want to provide additional detail.
Thank you. Come on screen too. Yeah, I'm curious with regard to the, you know, practice level care coordination that you were describing, but I'm also familiar with Medicaid health plans have, you know, are doing complex care management. So again, I'm talking specifically about the complex kids that both the physicians made reference to in their comments. And I'm just wondering about the intersection between plan level or practice level coordination with the health plans, and then also in some instances with local health departments, the Children's Special Healthcare Services Program, which is, you may know, I'm quite familiar with that as the CSHCS director. So I'm just interested in your experience on how the care coordinators intersect with each other, or if they do.
I can talk from my own experience. I can tell you we receive letters from the care coordination from the insurance companies, and I've sat on hold for over an hour trying to get a hold of the care coordinator to communicate with them. The ability to get access into the portal, they make it sound easy. I haven't been able to figure it out. So there's things that are built, but it just doesn't seem to intersect well with the practice and the third party payers.
Thank you.
Another question from Sarah Clark. Do Medicaid health plans benefit from PCMH? For example, do they get fewer calls to their helpline for members who get care at a PCMH? Sounds like that might be a good exploration for for somebody in the Medicaid data warehouse to look into.
Yeah, this is Lonnie. I'll just acknowledge, I think that's an excellent question. I'm not sure if this set of panelists would be well positioned to speak to that, but I agree it's probably something, it's definitely something that should be further explored.
Great.
I would say that a lot of the work does get pushed, like something that the insurance plan should be doing or informing the people who have their insurance of versus it being a thing that I wouldn't even say if it's just a PCMH model, but I do work for a PCMH, but some things they are, I feel, pushing for other people to do, and it should be something that they should be doing. I don't know if they get fewer calls to their helpline, but I would think so, because if somebody can call me and get a quicker answer than calling their insurance line, then it makes sense to call someone else or someone else who might, do it for you or help you walk you through it better than someone who works for the insurance company and they don't know as much as you think they should, or you keep calling, you keep getting different answers, stuff like that.
Mm-hmm.
Yeah, I know with the Upper Peninsula Health Plan, which is the Medicaid administrator in the Upper Peninsula, they do a fair amount of care coordination. And I don't know if it's because it saves them phone calls or if it saves them money, or it's one of those metrics that they use for quality assurance, or they report that out to to Medicaid generally. So I'm not sure what their motivation is, but they are doing it. They're doing it for a reason.
Yeah, that'd be a good question to follow up with one of our other panelists from last time, maybe. All right, well, we are coming to the end of our time together. I want to make sure we have some time as an audience to do a little brainstorming. And I put our brainstorm question in the chat here. What changes do you think are needed to make the medical home approach the standard of care for providers and families in Michigan? So this is for everyone on the call. Please put on your thinking caps. And what did you hear today about changes that you think are needed to make the medical home approach the standard of care for providers and families? We're going to give you a few minutes for brainstorming and in the chat. And while y'all are thinking and typing about your wonderful ideas, I just want to thank our panelists for their amazing contributions. I feel like I'm like in a college level course every time we have these conversations. So thanks for contributing, all your wisdom to this group.
Thank you for having us.
I don't see any brainstorms in the chat yet, but I hope you all are having your thinking caps on. All right. And I see some coming in. Great, thank you. And we will definitely track these and incorporate them into our notes and into our plans for the fall, when we'll be coming together to kind of make a plan together. So during our next meeting, which is scheduled for June 25th, so it should be on your calendar, we will hopefully be hearing more from our parent members, particularly about their experiences accessing healthcare for their children. So look for any communication from us about potentially participating in that. I think we may set it up more like a focus group or a fishbowl rather than a panel. So maybe a little spin on the model. And as always, your feedback is very appreciated and welcome. We look at every single thing you type, every single rating you give, and your feedback on last week's meeting was incredibly helpful. So evaluation link is in the, or will be in the chat if it isn't already. Thank you, Lindsay, for putting that in the chat. So we invite you to please complete the meeting evaluation using the REDCap link there. And I see some ideas coming in the chat. Pieces about measuring how we measure quality and effort can shape the care that's provided. Financial incentives being, a critical piece to look at. Concerted effort to help patients and families understand what PCMH is and what they can get from it. Yeah, noting the challenge of balancing care delivery with the realities of billing and data entry. So if there's possibilities for streamlining that or making data supports better. Some training opportunities. Good stuff. Thank you everyone for your brainstorms. We have a few more minutes, so I welcome you to kind of check out what's in the chat and build off it. If you see an idea that is of interest to you, please keep offering your ideas. I see a mention of sustainable funding streams and increased education across the board, so for providers and parents. Oh yeah, and parents advocating to insurance companies or others who make policies around why this is important to them. All right, lots of good ideas coming in. Financial uplift is what is really needed. Yeah, Dr. Gilmer, I think you're right. But she mentions what is more practical is parent or caregiver education to seek and demand from health plans that PCMH functionality, whether or not it's official accreditation. And parent narratives being a powerful tool of change. Yes, I think that's definitely a theme coming out for today. Cressy mentions looking at the model from the other side, how has it saved insurance companies money and improved care or care outcomes? And that goes back to kind of parent narratives. It goes back to looking at spending, goes back to some of those standards that are measured and how they're measured. Is it measuring the most important pieces regarding care outcomes? Tia mentioned, some of those pieces are really critical, needing providers open after hours and on weekends, maybe some daycare options, and why it's important to have a medical home versus going to urgent care or the hospital for the ED, for example. Yeah. Beautiful ideas. Thank you, everyone. Well, I'm going to adjourn us for today. But we'll be here for a couple more minutes if you're still typing away. We love your ideas. Thank you so much for this incredible time together. I hope you have a great rest of your week.